Hey, this is Sandy.
And Randy.
And we're here on AT Corner.
Being an athlete trainer comes with ups and downs, and we're here to showcase it all.
Join us as we share our world in sports medicine.
Welcome back to another episode of AT Corner. For this education episode, we are going back to the position statement series.
A good one.
Yes, we're talking about SLAP injuries. See, for all the people who watch on YouTube, they got a gem of a video clip right there.
And for all the people who didn't.
Nope, they're wondering what is this weird chaos that's happening at the beginning of this episode.
So first, let's thank our partner, Precision AT.
Big time.
For providing the CEUs on this episode. If you guys are now listening to it, it is free. If it is within our latest 5, it is free. And if it is not, then you can go down to the show notes and it will be behind a paywall. And is there bonus content for this?
Not this one, no.
No bonus content, but you will get the CEUs.
Yes, it is never too early to start thinking about those CEUs because it's coming.
You're right.
It slowly but surely it's coming.
So what are we talking about this episode?
Yes, so the objectives for this episode basically focus on the position statement that the NATA put out for the evaluation, management, outcomes of superior labral anterior-posterior injuries. We'll discuss the evaluation process of a SLAP lesion, and then we'll explain the non-surgical management of SLAP lesions.
That's good, because we're non-surgical.
Exactly. The position statement did do a pretty good job of just kind of briefly going over some surgical considerations, which I thought it was nice because it gave you enough information so as the athletic trainer, you kind of have a game plan if you have an athlete or patient that's going in for surgery to have some background information to educate your athletes or patients without giving you like bogged down on a lot of technique. So I did think it was really good, but I feel like most ATs really want to talk about more, okay, what can I control?
What can I do?
Yeah, what can I do for this? So
that's like something to look at it like if you have someone with a SLAP tear and they're going into surgery, you can like briefly read up on that and be like, oh yeah, I know what I'm talking about.
Oh yeah, for sure. And yeah, it's definitely for the students. You could really show off next time you're observing a surgery with like knowing these surgical techniques. But I thought it was the perfect amount of information. So hats off to the committee that threw this that did this position statement.
Nice. So Randy, what is a SLAP lesion? Let's start with there.
Yes. So a SLAP lesion is an acronym for Superior Labral Anterior-Posterior Lesion. So when you're thinking about the labrum or the glenoid itself, think of it as a face of a clock. So a SLAP lesion in particular occurs from the 10 o'clock to 2 o'clock position. So the most superior aspect of the glenoid is 12 o'clock, and the most inferior would be 6 o'clock. So kind of that top of the clock is where you're seeing this kind of lesion, and hence the superior portion of the SLAP.
Is the lesion more like a detachment, or is it more like a tearing, or can you help me picture that a little bit?
Yes, we'll talk about that coming up.
Okay.
But essentially, this top part of the clock, that 10 o'clock to 2 o'clock, is where the long head of the biceps actually inserts into that superior labrum. So now you can kind of see this relationship as we start talking about why that's important. So to answer your question, the types of lesions, so the lesions there's different type of grading scales to talk about a lesion, but the most common one that you'll always hear of, it basically grades it from a type 1 all the way to a type 4. So a type 1 SLAP lesion basically says there's no detachment. All it is you're seeing some degenerative fraying. So
like on the edge?
Yes. Yeah. So you're seeing some degeneration around that labrum where the long head of the biceps inserts, right? Type 1 SLAPs can be asymptomatic. So sometimes just because you find it on imaging doesn't necessarily mean like, oh, that was the problem. So keep that in mind. Now, the types 2 through 4 have basically some kind of degree of tearing. So as you get higher in the types, you see more tearing. So type 2, right, you get a little bit of detachment. Type 3, you're starting to see a bucket handle. And type 4, it's just a disaster. And essentially, you're actually seeing some tearing go into the biceps tendon itself.
I dare you to tell someone with a type 4 lesion that they're a disaster.
I feel like I have told an athlete that just in general. Just like, I don't know,
you're
man.
mean.
It's someone that you can joke with. Like, oh, dude, that movement was a disaster.
No, that's not what you said.
Okay. Usually the ones that are like a hot mess and they just got a lot going on, I'll just be like, bro, you're a disaster right now.
Okay, so now that we've identified what type they are, how does that actually happen?
So with the SLAP lesion and with, any type of labral lesion, you can have an acute mechanism, right? So it could be traumatic, like a dislocation, subluxation, right? Falling on our classic favorite acronym, the FOOSH, right? That can cause it, right? But what you see often, especially in overhead athletes, is that chronic mechanism. So this mostly focusing on those overhead athletes, right? This happens just from the repetitive load of, being a thrower, especially in the baseball, softball population. And there's two different phases that this can happen in that have been identified as areas where the biceps really pulling on that superior labrum. And that's the deceleration phase of the pitching motion. And what you see there is you see a lot of tension through the biceps being transferred into that superior labrum. So if you can think of your arm going through that follow through, right, there's the distraction force, right? The force of your shoulder basically being pulled out of the socket, right? Your body has to counteract that. But then you also have the eccentric load on the biceps that has to control elbow extension and the pronation from throwing. So that's a lot of eccentric load, right? Gets transferred right to that superior labrum. The next phase that has been identified is the cocking phase. So this is, as their shoulders going into that external rotation before they fire the ball, right? And they attribute this to what's called the peelback mechanism. Essentially, the biceps tendon has some torsion on it as you're going into that external rotation. That twisting causes tension on the insertion with the labrum. So both those mechanisms could be at play. It's kind of splitting hairs to say, which one's more dangerous? Well, in a throwing motion, you're doing them both. So I feel like that accumulation of just both those mechanisms, you can see there's a lot of load and there's plenty of potential for that labrum to get slapped. Yeah, you like that one.
That one caught me off guard.
Yeah.
Okay.
It was so effortless too.
Because I was gonna say you're not gonna be like, oh yeah, just don't do your deceleration.
Exactly.
Or don't do your cocking phase. Like that's part of throwing.
Yeah, let's just limit that motion. Just if anything, just underhand the ball.
Yeah.
Not too hard.
Yep. Let's see what coach thinks about that.
Yeah, I'm sure most coaches are gonna be good sports about that one.
All right. Someone's injured. We made it back to the clinic. What evaluation techniques am I using? What am I noticing? What are some key things that make this a SLAP tear versus just labrum?
So the position statement did a really good job of really focusing a lot on the evaluation process. And the reason I think that's very important is because once we get into the special tests, I'm sure students are going to love this portion of it because we all know about shoulder special tests and how super they are. But first, as with any evaluation, you got to get a nice, good history. So how the position statement laid it out was these patients that have a SLAP tear or the possibility of a SLAP tear, they're going to complain of vague, just deep shoulder pain. It could be between the AC joint and the coracoid process, so kind of going a little more anterior. But it can also either be posterior or the anterior glenohumeral joint. So you're really kind of seeing that like top C portion of your shoulder, that superior C. It could be anywhere within there.
Is it kind of like, when they do a C on their hip, when they hold their hip, they're like, oh, like this hurts my hip like this.
I would kind of look at it like that. The position statement didn't necessarily talk about a C sign, so kind of like a hip labrum would. But essentially that pain pattern can be anywhere within that C. So yes, kind of.
I feel like there's a lot of shoulder things that are just people point like that though.
Yeah, well, because there are a lot of structures that are involved.
That's true.
And a lot of those structures are within the same area. What the position statement did bring up was the fact that, SLAP tears aren't necessarily in isolation. There's a pretty good population that also have a rotator cuff tear in there as well.
Well, I was going to say, because if you're talking about deceleration, what is doing a lot of deceleration?
Oh, that cuff.
And also, if you're talking about humeral
Distraction,
what's
cuff.
keeping the humerus in the socket?
Exactly, the cuff. And if the labrum fails, well, the next thing is, well, we have to put more load on the dynamic stabilizers, which could fail eventually as well. And the next one that I've definitely noticed with like SLAP patients is they do get that like dead arm feeling. You know, their arm feels dead. They get like those sudden bouts of just weakness. And so that's definitely something to keep in mind.
That is also just general labrum, though.
Yes.
That's a bad feeling.
Yes, it's not good.
It really sucks.
You can also have a history of clicking and popping. Again, that could just be generic labrum to begin with. It is important to note, though, that this wasn't a standalone. So just because someone complains of just clicking and popping does not necessarily mean like, oh, yep, SLAP, right? A SLAP is a type of labral tear, right? So when you do research or like read the research on SLAP tears, right, they're so focused on one type of labral tear, right? So that clicking and popping could still be a labral tear, it just may not be a SLAP tear. And also some people's shoulders just click and pop. And athletes, it's always funny when you ask that question, because in our mind, I'm thinking of a clicking and a popping, catching, meaning one thing. And then when you ask the athlete, they're like, oh yeah, it pops all the time. And so then you're like, does that popping hurt? Oh, no. I'm like, okay.
Right. I could probably get my shoulder pop right now.
Oh, 100%. So those are kind of like those kind of history questions, some things to look out for as you're going through your evaluation, as with any shoulder injury. And, you know, kind of like what we talked about in a shoulder pain episode. We did I believe, an education episode on shoulder pain.
Yeah, probably a long time ago.
A while ago, right? You're going to want to look at range of motion. So range of motion isn't necessarily predictive of just SLAP tears. It's able to identify those that are at risk for general shoulder pain. So what you're trying to look for is a loss of greater than 15 degrees of horizontal adduction. So that's, you know, bringing your arm across your body.
You know what? That's actually a really good point. I don't know the last time I really looked at someone's horizontal adduction.
Yeah, it definitely is a good measure to look at for posterior muscular tightness or posterior capsule tightness.
Like the only time that I do that is if I'm
stretching
a deltoid.
Yeah.
Or attempting to. I feel like some people can't, like they're like, oh, I don't feel a stretch.
Yeah.
Okay, we're done with that one.
You'll also look at, try to identify any GERD, right? So that's a internal rotation deficit of greater than 13 degrees without a greater than 15 degree increase in external rotation. All right, we already know that overhead athletes, especially throwers, right, they do lose internal rotation, but you should be seeing an appropriate gain in that external rotation too.
So they still have the gross amount, it's just moved.
Yes, exactly. So that's one of the things you talk about is that total arc, right? The total arc should be the same between both shoulders or around the same. It's just you're going to see more external rotation on the throwing arm compared to the non-throwing arm.
Mm-hmm. So GERD is actually when the arc decreases.
Yes.
I don't think I knew that differentiation.
Yeah. It is important to, I mean, there are some definitions of GERD that just look at internal rotation, but I believe, if I remember correctly, it has to be like a big decrease in internal rotation. It's almost like 20 degrees difference. So it really kind of depends on the definition you look at, because there's definitely many different definitions. So it was really awesome to see the position statement also bringing that up, just to remind everybody, like, hey, like this is implicated in SLAP injuries and just shoulder injuries in general. And then, of course, we got to talk about the kinetic chain. Right, you're going to look at scapular motion. You're going to look at how the lower extremity is. The position statement didn't necessarily talk about like lower extremity factors that could increase the risk of SLAP. But I believe in that shoulder episode we did a while back ago, we do talk about some lower extremity factors that could be implicated as a risk factor for shoulder injury to begin with. And one that I think gets forgotten about, but I've definitely enjoyed doing it for like shoulder rehab, is the SC joint.
What? Wait, keep going.
Yes, looking for any like restrictions in the sternoclavicular joint, right? Because when you go overhead, this joint still has to move a little bit too. So if you have restriction there, it could be affecting the way the scapula moves and then therefore putting some extra stress on the shoulder.
So essentially just joint mobs?
Yeah. I've even done light tooling around there too.
Mm.
Yeah, good soup.
I feel like it's just like an uncomfortable area to work.
Yeah, could be. All right. So now that we kind of talked about just general stuff to kind of go with your rehab, it's time to go with the meat and potatoes that all students like to talk about, and that's special tests.
I like special tests for SLAP. I have one. I don't know what it's called.
Oh.
Maybe you're going to talk about it.
Okay, maybe. We'll talk about it. Let's talk about it.
I use it in all of my shoulder evals.
So, as anybody who's been through an evaluation class, there are tons of tests for the shoulder, especially when you're talking about the labrum, right? And essentially, if you go through the position statement, you basically find out that not one test shows great results.
It's the combination of them.
And I was just going to say, when you combined them, I even wrote this down in the outline. Now we're getting somewhere, right? So as with like a lot of, or what we've been noticing with, you know, certain musculoskeletal conditions, a battery of tests is better than just one test alone.
Yeah, a bunch of people together is a party.
Yeah, exactly. And that's the same way for tests. So in the position statement, really the tests the combinations of tests that they recommended, of course they recommended with caution, just because of limited evidence and just how many few studies there have been done on the certain combinations.
They just wanted a CYA.
Of course. They looked at test combinations that had a high specificity. So essentially what that means is if this combination is positive, there's a higher likelihood that you can rule in a SLAP tear.
Specificity in spin.
Spin.
Rule in.
That's right. So a SLAP tear can be ruled in if any one of these three combinations that the position statement listed. A history.
This is going to be so hard to keep track of.
It could either be a history of popping, clicking, or catching with a positive anterior slide.
Anterior slide is different than anterior. Oh, wait, anterior drawer is not. It's anterior slide in the shoulder.
Yeah.
That's the official name. Anterior slide.
Yeah, the anterior slide
I called
test.
it anterior glide.
Maybe.
Maybe
I believe it's the one where you put hand on your hip.
Oh, wait. So not like anterior drawer.
No, not like an anterior drawer.
Oh, anterior slide. Yeah. I thought that was like, you know what? I'm being completely honest. I don't know the names of the shoulder tests.
You just do them.
I do them. I try to document as best as I can, but I need to review them.
Yeah, anterior slide, I believe, is where you put
hand on hip,
and then you basically load it. Yeah.
Elbow, and you move front and back. You move the
elbow.
elbow.
So I've seen it explained two different ways. I've seen that one. Where you load, move back and forth, like you move the elbow, anterior, posterior. Mm-hmm. And then I've just seen it where, because you're loading it and like you're compressing, but it's also slightly anterior, that's just the test. And if there's pain or popping or clicking, that's also a positive.
I've had a positive. I really like this one because I've felt what a positive is. I've only ever felt a positive once. But
did they have a SLAP tear?
A labral tear.
Okay.
I don't remember. I don't think it was SLAP, but there was also shifting in the shoulder.
Oh, okay. Yeah.
Yeah.
Which would make sense if there's labral tear. And again, when we're talking about these tests, this is literally just trying to identify one condition, right? The position statement is on SLAP. It's not on labral tears. So that's another thing to keep in mind as well.
Wait, what?
So
the position statement is on
just SLAP.
Okay.
We're not talking about labral tears. So the numbers on the anterior slide and like stuff like that could be different when you're talking about a general labral tear compared to just SLAP.
We're just talking about SLAPs like Barney and Marshall.
Exactly. Yeah, exactly.
Mm-hmm.
All right. So the next combination you can do is the compression rotation test, a positive apprehension, and this one is common within SLAP literature is Jurgensen's.
Okay, I do Jurgensen like all the time, but it is so hard. I can't.
It is. There's a lot that's happening.
I've been doing this test for years and I cannot get my hand. I change my hand placement every time.
But it seems like, because like how I learned it was you also palpate the biceps tendon to see if it subluxes.
Mm-hmm.
But if you're not worried about a subluxing biceps tendon, you probably don't need to do that part of it. And you're really kind of focusing on the resistance to external rotation and elbow flexion. You're basically just trying to tension the biceps to see if it produces the pain.
Mm-hmm.
That actually had a 96% specificity when all those were positive.
Compression rotation is with them lying down.
Yeah, and it's literally you just load the shoulder joint and then just rotate.
Oh, it's literally called compression rotation?
Yeah. The name does actually describe the motion.
That is nice. And apprehension, like standard labrum.
Yeah.
Standard labrum plus bicep test. That kind of makes so 2 labrum tests and a bicep test makes a SLAP.
Yep, makes a SLAP.
Okay. Like 96% of the time.
So, well, and then it goes
96% we can rule it in.
Yeah, if they're positive.
If
all of them are positive.
No, that's what I'm saying.
The last one that they recommended or within combination was the compression rotation, apprehension again. But then I like this one. I'm a big fan. Biceps load 2. I don't know what biceps load 1 is, and I forgot. I know I looked it up, but I can't remember. But
can
2.
you please break that down? So
if you get a positive...
No, can you please break down what the biceps load 2 is?
So essentially, all the biceps load 2 is... I usually do it laying down. I think you can do it seated as well. Basically, you have their elbow and shoulder in 90 degrees abduction, elbow flexion, and then you just resist a biceps curl.
Oh.
Yeah.
That
again,
is very simple.
Tensioning the biceps. That's basically what you're trying to do because of the attachment into the labrum.
So compression rotation, which is labrum, apprehension, which is labrum, and then a biceps load test, which is biceps.
And
so
that
it's basically like... Go ahead.
I was just saying it gives you 90% specificity.
So if you're looking at compression rotation and apprehension, so the 2 labrum tests, and Yergesen or biceps, you can have a pretty good idea if you're dealing with a SLAP tear.
Yes.
Okay. If you get anything from this episode, just do compression rotation, apprehension, and a bicep test.
There you go.
If you think it's SLAP.
There you go. And it's also important to note too, like when these studies like look at these special tests, it also depends on the type too, right? Because we talked about there's 4 different types of SLAP tears. So it's like, it's really hard to do this kind of research because it really depends on what your definition is of SLAP. When you think SLAP, are you just trying to find type 3s or type 2s, right? So that could also limit a lot of this research. But in general, those are some pretty good ones that you can feel pretty confident that if all those are positive, you might be dealing with the SLAP. It has a very high likelihood. So now we talked about specificity. We got to talk about sensitivity. So sensitivity is your ability to actually rule it out, to say like, oh no, there definitely is not a SLAP tear in there. And the position statement really didn't have any combination of tests or many tests in general that showed really high sensitivity.
So it's easier to rule in a SLAP tear than it is to say, oh, this is not what we're dealing with.
Exactly. One of the things that the position statement threw in there was that the O'Brien test, which I know a lot of people feel that it is really good for like identifying labrums or identifying SLAPs. The position statement really highlighted the limited evidence behind it, and did not recommend it to identify any labral lesion, or at least a SLAP lesion, I should say. But I did go the extra mile in our position statement episode and looked at a current meta-analysis. So I think it was published in either 2021 or 2022. So after the position statement.
Mm-hmm.
And combinations that included the O'Brien test and the Crank test actually showed very high sensitivity to rule out a SLAP tear.
If they're both negative?
Yes.
O'Brien and Crank. Okay, so O'Brien is the one where it's the 2-part test.
Yes.
So you have palm up.
And then thumb down. And then you're also in...
Thumb down across your body.
Yeah. Which I learned it as a pretty good AC joint test.
Really?
Yes.
I only learned 3 AC joint tests.
Yeah, I learned it as being pretty good at identifying AC joint sprains. But when you think about the pain pattern of a SLAP tear, right, it's in the general area, so I could see how it still may be used.
Well, yeah, especially if that bicep tendon, if there's any inflammation in the joint, that bicep tendon is being crushed.
Yes. So how I look at it is, yes, the position statement does not recommend it fully. But with this latest literature coming out, I wouldn't necessarily say, oh, well, throw out the O'Brien's test. I'm never using it again. Forget this one. Done. No, right? Within a combination, it actually might give you useful information about being able to take out your thinking of a SLAP tear.
What's crank?
Crank, basically, you have them in about like 110, 120 degrees of shoulder abduction.
Mm-hmm.
And then you basically compress the joint. And then positive would be pain or like a
laying
shift.
Down?
Yes.
I don't think I'd name that crank.
Yeah, you crank on it.
That's more like compression.
Rotation. But it's also important to note that, again, it's not just these two. It's not just O'Brien and crank. It's combos that include them as well. So you're still doing Jorgensen's. You're still doing, there were a ton of tests that this study looked at in combination, and any one that included the O'Brien and crank increased its sensitivity. So if you like those tests that have high specificity, throw in O'Brien and crank, and you might actually get a combination of tests that has a pretty good sensitivity, because this meta-analysis didn't necessarily combine those ones. It didn't even look at biceps lobe too. So the idea is, as a clinician, as long as you're throwing in a combo of special tests, you might be okay.
I mean, you should anyway.
Yeah, you should. Shouldn't just do one test. But, right, so just because the literature just, well, it didn't have this test in the combination. Well, that's just because it didn't look at it. Doesn't necessarily mean that it's totally wrong. So as long as you're, hey, do those tests that have high specificity, maybe throw in O'Brien and crank, and then all of a sudden your sensitivity of all those gets better.
All right.
Yeah. And then they did have another one, which is the dynamic labral shear test, but there wasn't a lot of literature. I think only one study's looked at it. That one test had very high, a pretty high sensitivity. So maybe later in the future, with more literature, maybe it's a pretty good one. Maybe it's great when combined with other ones. So
I think that one's like supposed to be the gold standard test, not just for labrum in general, right? I heard that one's.
I mean, it's
really
it's a good test,
right?
Like, just the one study that looked at it had a very high rating. So, like I said, in the future, it might get a lot of support.
Mm-hmm. That one's hard for me because I have to make them like my height, actually shorter.
Yeah.
That's why I prefer the laying down one, but that test is so good.
Yeah. So if we get anything out of the evaluation portion of this, is go with a combination that is comfortable for you. Test that you feel comfortable performing and in combination, and then use that information, right? If you're using the ones with the combination that has a high specificity, if you get a positive out of those, you could feel pretty good. There might be a SLAP tear in here. If you use the ones that have very high sensitivity and you're not getting any, and all of them are negative, you could probably feel good that, like, oh, I am not looking at a SLAP tear.
Yep, do a couple labrum tests, add in a bicep test. There you go, you got a SLAP.
Boom. Got him.
All right. So what happens when we do have a SLAP tear?
Yes. So we're going to focus on the non-surgical side, because really with SLAP tears, their primary focus is doing a non-surgical approach first before going with surgery. And when I was reading the position statement, I thought this was crazy, man. I was like, man, this timeline's nuts. They recommended 3 to 6 months of conservative treatment.
Wow.
I know. I feel like I was like, whoa, that's a long time. But I guess, it is pretty significant though.
Right.
So essentially what you're trying to do with your non-surgical management, and I believe we talked about this in that shoulder pain episode to begin with, was you're basically going off of your evaluation, right? You're trying to improve any range of motion deficits that they have. So maybe increasing that internal rotation, increasing horizontal adduction, right? You're going to try and improve rotator cuff strength. And like I said, rotator cuff damage could be implicated in someone who has a SLAP lesion, right? So the rotator cuff is very important to the support of the shoulder. You're going to try and improve scapular dynamics, right? If the scapula is not moving properly, it's only going to close off that subacromial space, causing some impingement. Rotator cuff doesn't work optimally when the scapula is all over the place. So, right, there's a lot of different reasons why improving the scapula stabilizers, why that's important. And then, of course, the kinetic chain. Glutes, baby. All about glutes on this show. So that's essentially what you're trying to do with your conservative management. Now, if that fails, right, if you can't get improvements in pain, right, their function's still, as I would say, a disaster, right, surgical intervention may be necessary. And like I said, the position statement did a really good job of explaining options that are, available to the patient, student, or the athletes as well. So, I definitely would say try and go through those. And, it's a good thing for us to know because we can educate the patient a little bit, or we can ask questions about the procedures done.
Yeah. I had a baseball athlete a couple years ago who had a SLAP tear, and I rehabbed him. He was doing great. He took a long time. He took the whole season off. And then he went back to throwing. Felt great, and then re-irritated. I don't know if he re-irritated it or like as he was going back into, because he was a pitcher, as he was going back into like full bullpens, then he was like, man, it's starting to hurt again. I'm starting to get that same pain. And then he ended up having surgery.
So we'll actually talk about that in the outcomes.
Oh.
But essentially, the criteria that you're looking for to progress them to their actual functional activities is 90% of their range of motion regained. So that could also be like a comparison to the non-throwing shoulder. You're going to look for 70% of their strength regained. So if you are able to measure objectively, right, you're looking for about a 70% gain in strength compared to the non-throwing arm. And then if you are post-surgical, they're saying you should expect about around 4 months before you're able to actually return to your sport-specific activities, right? So there's still that criteria you want to hit, but it's also time-based as well. You want to hit that around 4-month mark, and then you're able to, do your return.
So it's not the end of the world, but it's
a significant time.
Yeah.
And I think like post-surgical, they about 6 months to be like fully good to go.
Okay.
For the post-surgical ones. But you can see like it could be a year depending on how long they want you to do the conservative management first, because that's just 3 to 6 months on its own.
Right.
But then also when you start talking about outcomes, right? So at the end of the day, this is what we're looking for as, clinicians, right? What are we doing for our athletes? Like, what's the outcome? Like, how do they look after they get done with this process? And unfortunately, with SLAP tears, the outcomes are not the best. And this is especially within the overhead athlete.
Outcomes like surgical?
Both.
Yeah.
Both.
My SLAP kid, after he had surgery, he didn't play again.
Yeah. Well, and I was going to say, in overhead athletes, there's actually a large number that don't make it, like, a lot of times they do it in like the professional baseball players. Mm-hmm. Like there's a large number that just had to retire because of it. Yeah, not a good look.
Everyone talks about Tommy John. They don't talk about SLAP.
Yeah, they don't talk about the SLAP. So the expectation is essentially that you should prepare your patients or athletes are that they should be around 85% of their normal function. And that's on average of 2 to 3 years. So this is still an ongoing process, even after surgery or after the non-surgical management.
Maturation and remodeling phase that lasts a couple of years.
Exactly. So like this takes time, right? So having a SLAP tear, right, it's a process. Even in surgical patients, only 67% of the overhead athletes were even satisfied with how they felt after the surgery. And satisfied, we'd say like they viewed it as excellent, like they felt really good. That's still pretty low, especially, going in for surgery, right? When you go in for surgery, you're hoping like, man, I'll feel pretty good, pretty good after, but unfortunately that's not always the case, especially in a SLAP tear. So outcomes still aren't great. So hopefully, as techniques get better, as rehab gets better, hopefully we can get that number up a little bit. But yeah, so far outcomes for SLAP tears, it's a tough road.
Do you have anything else with the meat and potatoes, or can we go into the action item?
I think we can go into the action.
I have an action item.
What you got?
We've said it a bazillion times. No.
Oh, okay.
Special tests, if you want to specificity in, if you want to spin, if you want to rule it in, compression rotation, apprehension, and a bicep test, either Yergeson and bicep load. So compression rotation, you can even do it while they're laying down. Compression rotation laying down, and then you just stop loading. You just put the shoulder into external rotation. They're the first two, so they're your labrum ones. And then you add a bicep test in. Boom. If you've got some positive tests, you can imagine it's a SLAP. Oh, we didn't talk about my SLAP test.
Oh, we didn't talk about it. Well, I was hoping it would maybe trigger it from one of those, but I guess not.
Okay, I don't know what it's called. I probably should have looked this up because I thought we were going to talk about it.
Yeah.
But essentially what it is you lay them down. I have to reenact this because
Do I need to lay down?
Arm goes into 120 degrees of abduction, and then you internally rotate their entire shoulder. So that is ideally, the idea behind it is stretching that bicep tendon, or it's like loading it.
Yeah.
Not loading like they're,
yeah,
like it's stretching it, and they should, if they have pain, it's positive. And
interesting.
Yeah, it's pretty good.
One is. I'll have to look that one.
I'm going to look it up while you talk.
Yeah. So essentially that is the action item, right? Like those combination of tests have a high specificity. The position statement did recommend them, obviously with caution. I would say the more take home is if you have a combination of tests that you really like that have, that you use for like labrum or SLAP, go with them. A combination can give you a lot better results than just one in isolation.
I found it.
What is it?
Passive distraction.
I've heard of that one.
It's really good. It's my favorite one.
I can't remember if it was I don't think it was the position statement. Maybe it was, I can't remember if it was the position statement or if it was the meta-analysis that I looked at that talked about it. I actually think it was the position statement, actually.
Oh, why didn't you include it? It's the best
But
test.
I don't think there was a lot of literature on it. It was just in isolation, I think. I'll have to double check.
Yeah, because the reason why I like it too is because, like, if you think about when they're in the position of like throwing, they're in that internal rotation.
Yeah.
And so you're basically recreating that. I mean, you're in shoulder abduction, but it's just because you're really trying to crank on that biceps.
Yeah. Oh, so crank.
Or distract.
Okay. Yeah, no, I do believe the position statement talked about it, but they didn't have it was just like, hey, this is a good single test possibly. There just was limited research for its specificity and sensitivity. So yes, hey, nice.
Thanks.
Yeah. And then obviously the management and evaluation in general, think kinetic chain, identify deficits and try to attack those deficits.
Nice.
There we go.
What references did you use for this?
I used the position statement, and there was one more. It was that meta-analysis. So we only used two, but this is the position statement series. So we were really diving into the position statement itself.
Right. So again, if you guys are interested in those CEUs, make sure you scroll down to the show notes. We do have every other episode as education or stories. This one was an education one. Our stories are coming back next week for a part 2 of our last week's episode, actually, because that one.
Yes, that's right.
We got a lot of stories for that one, so we have some more pros and cons to different settings.
ATs love talking about their settings, man.
Yeah, I mean it's where they are every day.
That's true. Oh, that's true. That is very true.
So make sure you head over to our Instagram to find out what story prompts we have in our Instagram stories, and also if you want to submit your story for a future episode. We also have a Facebook group, facebook.com/group/AT Corner Podcast, where we do a question of the week. I think the question of the week should be, do you know the names of your special tests? Because I obviously do.
You know what? I think for shoulder, that'd be pretty good. Do you know your shoulder special test names?
Can we quiz you?
Well, it's the twisty one. Do that. The rotating one.
Yeah. I mean, as long as I know what they are.
Yeah, right?
That's what matters. Anyway, super thank you to Precision AT.
Of course.
And
Megan and Mara are pretty dope.
They are awesome. We love them. So should you.
Very well said. I love it.
I think that's it.
Thank you for helping us showcase athletic training behind the tape. Bye.